Welcome to the February 2025 learning session. And we are going to have this is part of a learning series that we're doing through the Canadian Primary Care Research Network. So I'm going to start with a land acknowledgement. I'm going to tell you a little bit about the CPCRN, introduce and then I'm going to hand it over to Manuela, who's going to tell you something around some technology, and then I'm going to introduce the speakers. So I want to welcome you today from wherever you are in Canada. And today I am sitting on the unceded territory of the Musqueam people at University of British Columbia, and I would welcome you to put into the chat, if you can, where you are coming to us today from. And I'm very grateful for sitting on this unceded territory. So the CPCRN is the people that are hosting this learning series. And this learning series is last in a small learning series on integrated care. And the CPCRN's vision is to create a sustainable pan-Canadian learning health system supported by patient-oriented, practice-based research that improves primary care. Our mission is to facilitate research to spread and scale innovations by building and growing local practice-based research and learning networks and developing a primary care information system. So now I'm going to turn it over to Manuela, who's going to tell us a little bit about the technology that we're using today, because we're trying something out.
Thanks, Sabrina. Hi, everyone, and welcome. So yeah, we're quite excited that today we've just enabled a new translation feature with captions to allow some of our participants to express themselves in French. So what I'll ask you to do, for most of you who are Anglophone, you won't have anything to do. But just to double check, if you go to the three points at the bottom of your screen, that menu, and you go to show captions or captions, and you enable translation, you can pick your speaking language, and then you can pick the language that you would like the captions to appear in, which for most of you will be English. So you won't have much to do. I'm just going to relay that to others in French. Donc, bienvenue à tous, et on est content de pouvoir proposer donner la chance aux gens de s'exprimer en français aujourd'hui, et pour que les autres puissent avoir la traduction, les sous-titres en anglais. Donc pour ceux qui voudraient s'exprimer en français et avoir la traduction par contre en anglais quand les autres s'expriment en anglais, je vais vous demander d'aller sur le petit menu avec les 3 points et choisir choisir la traduction, le feature traduction, et puis mettre votre langue en français dans laquelle vous allez vous exprimer, et puis choisir vos sous-titres en anglais par contre, comme ça quand les autres s'expriment en anglais, vous aurez les sous-titres en français, excusez-moi. Voilà. I hope that's clear for everyone, and I will put the instructions in the chat. Thank you.
Okay, great. So I am so happy to introduce our panel today. So today we have Dr. Catherine Hudon, Marie-Dominique Poirier, Walter Watches, and Bill Lachance joining us today, and they will be talking about scaling up integrated care, challenges and successes from 2 points of view. So despite the potential of integrated care to improve patient experience, population health, team well-being, cost, and health equity, scaling it up raises a number of challenges. Panelists will provide key learnings to date from the PriCARE program, as well as they'll also discuss strategies to knowledge translation and mobilization across transforming health with integrated care teams, and opportunities for closer collaboration with the Canadian Primary Care Research Consortium, which includes the Research Network, the Sentinel Surveillance Network, as well as the Trials Network. So specific objectives today are to identify lessons learned about scale-up of an integrated care program, and to understand how to apply principles of knowledge translation across research networks, the Network for Integrated Care Excellence Canada. and I will turn it over to Catherine.
Yes, thank you, Sabrina. So I will share my screen. It is okay. You see it? Okay,
Yes.
great. So, hello everyone. I'm Catherine Hudon, professor at the Family Medicine and Emergency Medicine Department of Université de Sherbrooke. I have the pleasure of being with Marie-Dominique Poirier, a patient partner who works in our team, and Philippe Lachance, a partner from the Quebec Ministry of Health and Social Services. So we are delighted to be with you today to discuss the lesson learned from the implementation of our integrated care program. Before we begin, I would like to hand over to Marie-Dominique, who is going to talk about the importance of integrated care. Marie-Dominique.
Hi, everyone. I am patient partner in the team because 27 years ago, pain took a big place in my life. I had and I have two excellent cares, but the pain take all the place all the time. I have the big chance to have a good nurse to take care of me and help me to regain control of my life. 27 years, 27 ans plus tard, the pain is still here, but it doesn't stop me. It driving me to like a force who led me to be involved as patient partner in the chair of Catherine Hudon.
So thank you, Marie-Dominique. You share an eloquent testimony of the relevance of integrated care approach. We would also like to share with you another real-life example of someone who suffers the harmful effects of a chaotic care pathway in the healthcare network. Indeed, Mr. Pierre Côté is a 54-year-old man who suffers from several physical health problems and has mental health issues. His social situation is really precarious. Although he is registered with a primary care team, he has still visited the emergency room 124 times in the last year and has been hospitalized 7 times. This interaction between physical and mental health problems and a precarious socioeconomic situation can result in complex health needs and extensive use of health services. Studies show that nearly 20% of people in primary care have complex needs. This population often has negative experiences and an uncoordinated journey through health and social care systems and suffers from poorer health outcomes and elevated mortality rates. Health and social care providers may feel powerless to meet their needs. This population also faces major health disparities. These unmet needs can result in high healthcare costs. In Canada, nearly 80% of healthcare costs, so 344 billion in 2023, are attributable to 10% of the population. A study conducted in Quebec showed that 25% of emergency room visits are generated by 5% of users. What can we do to improve the situation and offer services that better meet the needs of this population? We will present the Visage approach, the process currently being scaled up in Quebec, and the challenges encountered and solutions developed to date. What is the Visage approach? In summary, hospital case managers work in collaboration with case managers in primary care clinics and partners in the health and social services network and the community network to improve the coordination of services for people with complex needs. The approach makes use of information systems to identify patients and includes aspects of governance and consultation tables. We have developed a comprehensive toolkit, including identification and standardized assessment tool, a standard of care, and so on. Implementation tools are also available. Hospital case managers have a dedicated full-time position, while those in primary care clinics integrate coordination activities into their usual tasks. The four main components of the approach include assessment of the person's needs and priorities, development of an individualized service plan based on the person's priorities in conjunction with health and social services and community network partners, coordination of services and assistance with navigation, and support for self-management. The Visage approach can improve the 5 outcomes of the quintuple aim. We have been developing, evaluating through several research projects, and improving the Visage approach since 2012. In line with the revised Medical Research Council framework on the evaluation of complex interventions, we have conducted projects using different research designs, often mixed methods, to answer the different research questions of our partners. In 2018, we launched the PriCARE project, which brought together partners from 5 Canadian provinces, including 8 patient partners, to evaluate the implementation of case management in primary care. We got through the major pandemic slowdown by sticking together. Several partners have contributed to the success of this program. We would like to take this opportunity to thank them. Here is part of the team during a face-to-face meeting day in Montreal after a few years of virtual meetings. The aim today is not to present the results of the evaluation. For more information on the various studies, please visit our website where they are detailed individually and where you can find links to all the published articles. Here are a few examples of published articles. The Quebec Ministry of Health and Social Services has been a partner in all the projects from the outset. Around 2020, they began to think more seriously about scaling up. In 2021, they funded a pilot project to evaluate the implementation in 2 integrated health and social services centers and 5 affiliated family medicine groups. This pilot project has enabled us to learn several very relevant lessons, including the challenge of identifying the target clientele in real time and the need to improve our identification platforms, adopting medical remuneration compatible with the desired level of commitment, and putting change management mechanisms in place. The pilot project also enabled us to finalize the development of a toolbox that includes interactive web-based training models, several clinical tools, including a standard of care, Connect 6, a screening tool, Portrait 10 to assess biopsychosocial complexity, and various other tools. Following the pilot project, the Quebec Ministry of Health and Social Services decided to scale it up across the whole province. At the same time, the CIHR launched their call for projects transforming health with integrated care. In 2023, we obtained funding to evaluate the scaling up of the Visage approach in Quebec and New Brunswick with Shelley Doucet's team. I saw that a few members of her team were on a call today. So I would now ask Philippe to explain what convinced the Ministry of Health to proceed with the scaling up. So Philippe, à toi la parole.
Merci Catherine. Est-ce qu'on m'entend?
Oui, on t'entend bien.
Super bien. Donc, je comprends que c'est pour moi le micro en français, donc je vais tester vos fonctionnalités de transcription en temps réel. Ce qui est intéressant ici, c'est de vous exposer, je crois, la dynamique qui a eu cours dans les dernières années entre l'équipe de recherche et le ministère de la Santé, effectivement. Donc, au départ, en fait, je ne me sentais pas du tout concerné par ce projet-là, en toute honnêteté. Moi, personnellement, j'étais à l'époque directeur de la première ligne, donc je m'occupais surtout des groupes de médecine de famille au Québec, principalement. Le projet était financé par mes collègues qui s'occupaient davantage des urgences au Québec, donc je le regardais avec attention, mais sans trop me sentir concerné, jusqu'à temps qu'il y ait des rapprochements de fait entre les deux équipes, puis des contacts de pris avec l'équipe de recherche, donc avec Dr. Hudon. pour me faire réaliser qu'il y avait effectivement peut-être des opportunités puis des zones d'arrimage dans nos dossiers. Donc, on a saisi une opportunité de positionner l'approche visage dans la révision complète de nos orientations au niveau de la gestion de la maladie chronique. Donc, on a pu présenter l'approche visage comme étant complémentaire parce que beaucoup de clientèles qui pourraient bénéficier de l'approche visage sont atteints de plusieurs maladies chroniques. Donc, pour nous, on voyait là donc une opportunité importante dans le cadre de la révision de nos orientations. Et on a pu présenter tout ça jusqu'à nos hautes autorités, jusqu'aux sous-ministres en titre. Le défi, on a même présenté donc des demandes budgétaires là, pour permettre le déploiement du projet. Et le défi a été de le faire prioriser au niveau budgétaire. Donc, on est toujours en train de travailler avec Dr. Hudon pour poursuivre cette mise à l'échelle-là jusqu'à temps qu'on trouve le bon moment pour repositionner les demandes de financement. Qu'est-ce qui m'a plu là-dedans? C'est l'aspect clé en main, hein, l'aspect le projet était très, 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 très complet. Le projet démontrait clairement la valeur de cette approche-là à l'époque dans la gestion des maladies chroniques. Aujourd'hui, davantage dans l'intégration des services, qui est une thématique pour laquelle on est en train de se pencher au Québec dans le cadre d'un chantier qui vise à établir une politique gouvernementale en soins et services de première. Donc, voilà, c'est le témoignage que je voulais vous faire aujourd'hui. Catherine, je ne sais pas.
Oui, ben merci Philippe. Les gens pourront poser des questions. Il va y avoir une période de questions à la suite. Alors, il y aura probablement des questions pour toi à ce moment-là. Merci beaucoup. So following the steps suggested by Milet, we first developed a scaling plan. At that time, we had confirmation of a recurrent budget from the Ministry of Health and planned to roll it out in group of 3 to 5 establishments. We had analyzed the challenges and potential levers. We had considered a form of governance to liaise with the ministry and the establishments, and a form of governance proposed within the establishments. We had also planned a communication plan with the ministry. The first year was spent preparing for scale-up. We finalized the toolbox, mainly the English version of the training models and the implementation guide. We consulted with various partners, including other directorates within the Ministry of Health and Social Services. We set up a community of practice that organizes meetings every 3 to 4 weeks with case managers. These meetings allow them to discuss different situations they have experienced in order to develop their skills. It is also an opportunity to invite experts and discuss more complex topics such as mental health, addictions, homelessness, and so on. Finally, we have worked with the team from HEC Montréal Pôle Santé, who have supported us with change management. A Ministry of Health resource working with our team has been identified to provide clinical support to case managers and the first cohorts establishments. Scaling up is underway in an initial cohort. An action plan has been developed by each institution. 12 case managers have been hired. A steering committee has been formed, including a project manager, a patient partner, a representative of the ministry, the 2 experts of the Visage approach, and an expert in change management from HEC Pôle Santé. The steering committee meets with the implementation committee of each institution every 6 weeks. We have decided to implement the approach in 2 phases in each territory, starting with the case managers in the establishments. The deployment of case managers in primary care clinics will take place in the second phase, approximately 6 months later. The case managers in the establishments will identify and refer patients to the case managers in their respective clinics. The presence of well-trained case managers in the establishments will promote capacity building for case managers in the clinics. I will now hand over to Marie-Dominique so that she can share her experience with you and tell you about her involvement in the scaling up to date. Marie-Dominique.
Je vais poursuivre en français, moi aussi, c'est plus rapide dans ma tête. Comme patient partenaire, il m'est arrivé une chance incroyable, c'est de pouvoir assister à l'implantation d'un projet de recherche, ce qui est très, très rare. Puis en plus, j'y assiste du point de vue d'un collaborateur patient qui arrive avec des expertises différentes. Je suis patiente partenaire, mais dans ma vie aussi, je suis enseignante. Donc, ça me permet de combiner mes deux savoirs. Ça permet aussi à toutes les personnes impliquées de réaliser que c'est des processus, c'est des chiffres, c'est des outils qu'on développe, mais c'est fait pour des personnes et par des personnes. Puis mon point de vue, qui est complètement différent, c'est sûr, est aussi valable que les autres. Ça m'a aussi permis, moi, comme patiente partenaire, en étant impliquée dans l'implantation, mais en étant dans les rencontres au ministère, de voir l'autre côté de la médaille, le côté que les patients, on ne voit pas souvent, puis ça a fait évoluer ma perception de mon rôle de patiente aussi. Oui, je disais, je permets aux gens de voir qu'il y a des gens derrière les chiffres aussi, mais ça me permet de travailler avec les équipes parce que je suis présente aux rencontres du projet d'implantation dans les milieux. Ben, les gens qui sont là ne se sentent pas gênés de me poser des questions parce que je ne suis pas une patiente qui suit, je suis une patiente avec qui ils travaillent. Je peux aussi proposer des pistes de solutions. J'ai travaillé sur les outils qui sont développés, puis je participe, comme toute autre personne de l'équipe, au processus décisionnel. Puis ça, je leur dis encore, pour un patient, c'est vraiment une chance incroyable de pouvoir influer sur le système de santé. Puis de moi, ça me ramène au fait de dire que, comme patiente partenaire, avant l'approche visage, j'ai eu quelque chose d'assez fantastique qui m'a permis d'aller là. Ben, mon espoir, moi, c'est qu'avec ce processus-là, ben, ça puisse se diffuser encore plus, puis que d'autres patients puissent faire comme moi, puis aller mieux, parce qu'il y a des gens qui vont avoir mis du temps pour ça. Fait que ça me donne espoir dans notre société.
Merci, Marie-Dominique. Everything looked good in 2023 when the ministry took the decision to scale up the visage approach. But the political and economic context changed dramatically in less than 2 years. The minister set up the Santé Québec agency to manage the operations of the health network, and Santé Québec is starting its work with the challenge of cutting 1.5 billion from health spending. These are realities that have a major impact on the scaling up of an intervention. Patience and perseverance have been valuable assets along the way. We have concentrated on finding solutions to the challenge encountered. This journey is just as rich in learning as the results that will be obtained at the end. That is why we would like to share some of the challenges and successes with you today. One of the major challenges is that of funding. We started scaling up in 2023 with the addition of a recurrent budget that was cut in the context of budget cuts of 1.5 billion. The first cohort of organizations had received funding letters, and some had already hired case managers when they learned of the budget cut. We spent a few weeks in the autumn 2024 with the question of whether the establishment would decide to continue or not. Fortunately, those who had hired case managers decided to go ahead despite the budget cut. Senior managers said they were convinced of the relevance and usefulness of the approach from a global perspective. They have found strategies for converting or optimizing certain resources to enable the hiring of case managers who have a very structuring effect for several departments. They have also evaluated the potential benefits in a comprehensive manner, including the avoidable costs of emergency room visits and hospitalizations. We need to think about a more comprehensive and integrated management of budgets if we want to succeed in better integrating care. Another challenge is that of integration at the systemic level. Attention and integration efforts are often focused on clinical, professional, and organizational aspects. But it has been observed when working more closely with the ministry that the various directorates often work in silos. This slide is long and the aim is not to read it in detail. I wanted to show you the poster that Marie-Ève Dupont, a PhD student in our team, I think that she is here today too, presented at the NAPRA conference in Quebec City. She is working on a case study with the Quebec Ministry of Health and Social Services on systemic integration strategies. During the planning and preparation phases, we organized several meetings with different directorates of the Ministry of Health and Social Services. The ministry continues to organize roundtables to promote consultation. In previous projects, we had also already noted the challenges that can result from inadequate governance in the institutions. It is essential to avoid putting all the pressure on the case managers. The implementation of the approach must be institutionalized and not rely solely on a few individuals. A clear and strong vision must emanate from the general management, and all levels of management must support the implementation. All of this underpins a good communication plan. When case managers start to follow patients, they identify various problems in the program criteria or in access to various services. This information must be able to be quickly passed up to the appropriate decision-making level so that lasting adjustments can be made. Case managers are not usually in a decision-making position to make these changes themselves. There is also the challenge of identifying target patients. This has been a recurring topic of reflection over the last 12 years within our research program. Several other research teams have also done interesting work on the subject. Our main conclusion is that we need to identify the patients who are most likely to benefit from the approach, while favoring a method that is simple and easy for clinicians to perform. Various more complex algorithms may perform very well statistically, but not be easily accessible to clinicians. A meta-analysis confirms that heavy users of emergency services are often heavy users of various health services. Since not all heavy users of services necessarily have complex needs, we have developed and validated a tool for detecting complex needs. The negative predictive value of Connect 6 is excellent, 95%, making it possible to exclude complex needs. When the score is positive, a review of the file often quickly confirms the complex needs. The challenge associated with case managers taking on a new role should not be underestimated either. Approaching these vulnerable client groups and implementing a personalized service plan are steps that require adequate support. As explained earlier, in addition to the training and the clinical toolbox, an implementation guide is available for managers and project managers, and we facilitate a community of practice. What are the next steps? First, each establishment follows indicators to enable it to situate itself in terms of process and outcomes in order to promote continuous improvement and sustainability. As mentioned previously, we are conducting a large-scale study to evaluate the implementation. We plan to have convincing data to present to the Ministry of Health and Social Services and to Santé Québec over the course of the next year for the funding of the full implementation in Quebec in the coming years. Thank you very much for your attention. I would also like to thank Marie-Dominique and Philippe for their valuable support and for being here with us today.
Thank you, Catherine. That's great. I think what we'll do is we'll move over to Walter, and then once Walter is done, we'll have some time for questions. Walter?
Awesome. Thank you very, very much. I am looking forward to this. And thanks very much, Catherine, and your colleagues for sharing your program, which currently is part of the THINK, Transforming Health with Integrated Care as well. Can everybody see my screen okay? Yeah, and you can hear me too. I can tell from your nods. Lovely. Sorry. I'm here to talk about a knowledge mobilization for the Transforming Health with Integrated Care overall program. So Transforming Health with Integrated Care is a CIHR program, and it has several elements to it, one of them being the implementation science teams. And the overall goal is to improve coordination of care and services around people's needs and improve the integration of care, coordination across the life course, encompassing intersectoral collaboration, and all the things actually that Catherine just spoke about. Think aims to expand share across the country. These are the elements of the think. So there were just arrows in that prior diagram. Those arrows actually represent the 5 elements of the think program. And that there were catalyst grants. They were 1-year grants that came out and they rolled out and they finished about 2 years ago. Then there were policy research for health system transformation, another series of 1-year grants that ended last year. The biggest piece is these implementation science teams. I'll highlight that a lot more because that's where the investment of nearly $30 million has gone. There are also, many of you have heard about embedded scientists, early career researchers, and what they call the Health System Impact Awards and Fellows, and they are considered to be part of this initiative as well. So all of those elements are considered within this Think initiative. And so our program, the Network for Integrated Care Excellence, is the knowledge mobilization and impact hub for all of this. And I'm going to speak most specifically to the implementation science teams and how we're working with them. But just to, our background is that, we also are aiming to integrate the knowledge and evidence that has come through all of these programs. The objectives for our hub are, first off, to foster coordination, collaboration, and shared learning among the Think grantees, and then more broadly. We are supporting capacity development in critical areas to ensure the success of grantees and helping them achieve their goals. So taking our knowledge mobilization expertise and sharing it into the teams and embedding it to expand and amplify their collective impact, and really being the lead for the knowledge mobilization and evidence sharing activities. So today is being, just telling you about this as part of it and engaging with you on how can we work together with CPCRN, which I think is just a fantastic opportunity for us. This is our leadership team, myself and my co-lead, Jodine Goldhar. And then we have representation of our leads in each of, a number of key areas. So knowledge user champion, community champion, patient family caregivers, Indigenous, sex and gender, and diversity, equity, and inclusion. And so these individuals come from Ontario, Alberta, and Quebec, and we aim to have membership across all of the provinces and territories as we mature as a network and an organization. Here's the broader team, again, made up of individuals from those 3 jurisdictions. So what are we tasked with? So the Think initiative I laid out on the outside, that's these 5 streams, and we kind of try to interweave these together and then achieve that goal that I set out for the Think initiative on the right side, which is person-centered integrated care. And so how is that knowledge generated from the teams going to turn into this integrated care? Well, that's our job, the network. So let me lay out a few of the ways that we are advancing. So we said we talk about some of our knowledge mobilization activities. So here are the main activities that we are landing on that we will, we've already started implementing these, and I think there's a lot of alignment. So first off, a series of learning communities, and I'll detail those a little bit, and they are going to start with membership from the implementation science teams, but we envision that within the 2nd to 3rd year that they will expand to include membership from a wide array of individuals interested in these focal areas. And there's going to be an invitation to CPCRN to participate in those learning communities. We are undertaking evidence syntheses, both of those past research grants and also of new and emerging evidence, working on developing policy briefs from those so they can be readily available when questions come from ministries or other system stakeholders, and also recruiting questions from those system stakeholders and developing policy briefs in response to those questions. All of this will go into a resource library that will be sustained over time. And then we have a number of other kind of activities that we're undertaking it. I'm not going to get into all of them, but because most of them are not quite in place yet. But over time, as we generate this knowledge, we'll be running separations of workshops, webinars, and policy dialogues. So here's a core activity that we're starting up this year. And I'll talk about two core areas. This is one. The first is Think Learning Communities. So we are bringing together the teams, each have 20 to 30 members, these implementation science teams, such as Catherine's. And we're going to organize a series of learning communities. And these are the focal areas for it. So we're actually starting with some of the researchers and the program managers. So the orange researchers, and then the orange, and then the sort of blue turquoise program managers, but also there are providers involved in all of the teams. So bringing together those providers and provider organizations to understand what their challenges are, why they're participating in implementation science teams, and have shared learning across the different programs and teams. Also to develop and foster knowledge mobilization and sharing amongst the knowledge users. So Philippe, you might have an invitation to participate, for example, in that, as we have knowledge users from each of those teams that are to understand kind of what their shared challenges are across the country and some of the opportunities, how people are advancing and overcoming some of the policy and practical barriers. And then we also have a community that is designated and co-designed with persons with lived experience that are part of those teams as well. So there can be sharing. And we had quite a good opportunity back in the fall with our first meeting, which we undertook in person in Calgary across the implementation science teams. And we had tables of these different groups, and we know that there are commonalities and good reason for them to be sharing. This is, the science side of things is we're approaching this from an evidence-based approach in a number of ways. One is the knowledge to action framework, co-designing with the community what the objectives are for each of those learning communities, and ensuring then that we're bringing into those evidence-based practices, and then also shared learning and evaluation of how are they even evaluating, how are they thinking about their implementation, how are they undertaking that work, so there could be shared learning across the communities in that regard. Our intent here is to really first support and strengthen the implementation science teams, and then to spread that capability out to others doing implementation across the country. So again, we might have very good reason to be joining CPCRN in that. We also have a learning series initially for all membership of the implementation science teams, but that will also expand primarily through our partnership with the International Foundation for Integrated Care Canada. And it will center on 11 pillars, 9 of them from the International Foundation for Integrated Care knowledge tree. There are 9 pillars of integrated care there. So everything from thinking about population health and well-being, how are people considering population health in their integrated care programs, all the way out to aligned payment systems, how are these being funded. We also have a specific emphasis in equity and in implementation science, given the focus of the Think program as a whole. And those are not actually explicitly a part of the knowledge tree in integrated care, but they really need to be. So we're adding those bits. So this is how we're, what I've just summarized are those activities in the middle that will get us from the Think initiative to the person-centered integrated care. So opening it up for collaboration now, this is a bit of the implementation science teams. So we do have 3 teams that are primarily in Quebec, but you see there's representation from every province. And this is kind of our starting network, are these implementation science teams across the country. And I kind of map this up then against your starting network, or your initial network, as I understand it, the practice-based learning research network. And so you can see you have hubs also across the country, and there's just a natural layering. I think there's actually synergy. You have membership that is in common with our membership. And I think there's just an absolutely natural synergy there. One of the things that we are working from, so I mentioned in passing, International Foundation for Integrated Care, which is pan-Canadian, but also has a global reach. And that might be another area where we can synergize. So we're bringing in the Think initiative into IFIC Canada, and webinars. And I think that would be a really great space for us to partner with CPCRN, is to bring your evidence into this broader community and stretching out beyond the people that you're already in engaging with and interacting with. And we have a global network of over 4,000 people that are following our work. We regularly have we have a quarterly series of webinars, and there are usually, you know, at least 200 to 300 people that are attending those, and you know the reach and is going beyond that. And so I see a couple opportunities here for connection and collaboration. One is, you know, this sharing of knowledge and exchange. So you've done an integrated care series, which has been great. I've actually joined one of the previous events. And so how do we ensure that sharing is amplified? We think that we really need to have a much stronger connection between primary care and primary care providers and integrated care. Because, you know, to us, you can do small elements of integration or integrated care pathways that do not involve primary care, but to actually have integrated population health, you need to be based and embedded entirely in primary health care. And we are really actively seeking to have a strengthening in that regard. You know, just some loose suggestions, which I kind of alluded to along the way, is I think there's really going to be great opportunities for shared webinars, contributions to the knowledge base. We're interested in taking what's happening in the practice networks and putting it into the knowledge base that's then more broadly available outside of the community you already have. You're making it available, but I think we have happy to be a conduit and you know, a bit of we think of ourselves as a bit of a megaphone for good evidence-based practice in this space. We're starting up with our learning communities to be initially with the implementation science teams, because we have a bit of an obligation in that regard. But we view those learning communities to not in the sustainability in the long run. They'll be supported by the IFIC Canada, and that will be much more inclusive. And so really by years 2 and 3, we would hope that we would have membership from your group as you're interested to participate in some of those learning communities and this, you know, engagement of CPCRN in IFIC Canada as primary care hosts. The last bits I really have here are just around, we are forming all of this in an amplitude that really leverages collective impact. So we're looking for common shared partners that have this, you know, shared vision and agenda, mutually reinforcing activities and continuous communication. So those are the elements that we are really looking to include and amplify. A couple of the things, like just so you know how we're working, we're just getting started. We really started up in the fall. And we had our first in-person symposium. We are launching this learning communities starting in the spring. Catherine will be joining and some of her team perhaps joining a meeting later in March where we're talking about this more generally. And we're going to have this learning series launch as well. And then having some cross-cutting theme sessions that'll launch in the following year where people are coming together to address problems and issues and challenges, primarily led those challenges will be led by knowledge users. So what are the challenges that knowledge users are facing so that we can bring solutions and knowledge to meet those challenges? And our intentions are then to have 2 follow-ups of all of the teams meeting in alignment with other meetings, one in Quebec in the spring of 2026, and then another in Ontario in the fall of 2027. I didn't have time, but I will just mention that we have we're developing a very strong Indigenous approach in parallel to this process, and that will be co-designed with Indigenous communities, and also ensuring that we have, you know, an equitable approach to sex and gender and many other aspects related to integrated care that are really important for us to do. So I'll kind of open the conversation along those lines, and I'm really interested in, you know, how do we work with, you know, your network? How do we share common pathways? I think there's a lot of synergies. I know I speak often with Sabrina and sometimes with Katrine, and I do know that we have a lot of overlap. I recognize a good number of the names in the boxes here on the screen. No, there's another face I recognize as well. And so, you know, we're happy to answer questions, but also just to develop opportunities. We think we need to have a much stronger emphasis and basis in primary healthcare. And I think this is the best network for us to partner with.
Yeah, that's great. Thank you. Thank you, Walter. Wow, I have so many things to say, but I won't. I want to open it up to people that may have questions, particularly around Visage, Catherine Hudon's work, representing one of the teams, and then also the comments that Walter has made on the Think. O'Neill. Wait, you're on mute. You're on mute.
We can't hear you.
Okay, now you can hear me? Okay, so thank you all for that presentation. J'avais une question pour Philippe. Attends, je vais mettre mon langage. Attends. Bon, si ça aide. Bon, alors, tu sais, ce que Catherine a fait de bâtir Visage, faire l'évaluation, démontrer sa valeur, c'est un peu l'idéal, c'est le rêve de la plupart des chercheurs. Puis quand tu dis que tu as vu ça, puis tu as dit que c'est un modèle clé en main, c'est intéressant, on peut travailler avec ça. Peux-tu nous parler d'un peu qu'est-ce qui t'a attiré? Quand tu dis clé en main, qu'est-ce que ça veut dire pour toi?
Ça veut dire que la preuve était faite, dans le sens où ça fait pas de sens aujourd'hui que je sois pas capable de le mettre à l'échelle de façon plus rapide que ça avec Catherine, parce que quand on prend le temps de lire tout ça, c'est béton. Je veux dire, on n'a même pas de question à se poser sur la pertinence ou pas de faire ça. Ceci dit, et c'est là que le défi de l'interface avec les politiciens, les gouvernements entre en jeu. Et souvent, c'est une question de timing. Puis là, ben, des fois, le timing n'est pas là. Puis là, ben là, Catherine l'a dit, on a un déficit important au Québec. C'est pas le bon moment de parler d'un développement d'une nouvelle approche aujourd'hui avec du budget récurrent. Bon, mais c'est partie remise. Donc, et donc, si je reviens à la question de clé en main, c'est que dès que j'ai une attention de mes autorités, ben, j'ai tout ce qu'il me faut pour être capable de le vendre. Mais le défi, c'est d'avoir le moment pour en discuter puis en parler avec ces gens-là.
Merci.
Great, thank you. Monica.
Thanks, Sabrina. My question is for Walter. Walter, I'm Senior Manager of Primary Healthcare with Government of Newfoundland and Labrador. I'm really interested in your presentation and the Think program, and I have heard some details of Think before. And I guess I have a comment and a couple of questions. In Newfoundland and Labrador, we do have a policy framework for a team-based care model for the province known as family care teams. I can share that framework in the chat. A key attribute of those teams that we envision when we develop the framework is the integration of primary health care with other aspects of community health, be it population health, mental health, and addictions. In our province program known as the Community Supports Program, all of those programs are under the umbrella of our one provincial health authority. So as we are establishing these teams, the integration is yet to evolve fully, but I see much opportunity. I'm really interested in how we can link in with Think if there's opportunities. I saw on one of your slides, Newfoundland and Labrador is already identified there. I'm thinking that is possibly through the Prime network and Dr. Chris Aubrey-Bassler's work. I'm thinking that might be it, but I'm curious as to how we can get involved if there's opportunities, and certainly it fits with where we need to go next with our family care teams.
Thank you very much, Monica. And I think that that's a really excellent opportunity. I think Allison Luke is on the call, and I think Allison is from, Allison, are you from Newfoundland? I'm trying to remember.
I am not.
Oh,
I'm not from. I'm from New Brunswick.
New Brunswick. Sorry, I knew it was East. I'm very sorry. That is.
That's okay.
Shouldn't make that kind of an error. But we do have a team that is has. But I think I'll say this, Monica. We are intending, like our creation of a learning community around knowledge users, you are exactly the kind of person that we want to engage in that work. To understand, like, what are your challenges in those implementations? And I can think of, lots of work that IFIC Canada has been bringing to the forefront that would address exactly what you're talking about. And I think we have a knowledge base, and making connections between you and some of those the past individuals who have experience in implementing these models. I mean, I think you're learning today from Catherine and the Visage model, and we have many other similar examples. There's also a strong connection with social prescribing is one of the thoughts that comes to my mind, of that connection, and how do we embed that within primary healthcare to make the network work. So that, including you in the learning community around the policy knowledge users, that would be the best way, I think, to link you in and ensure that you are part of the IFIC Canada community as well. So thank you for your comment and your question. Sylvia has it, Debbie Kelly's team. Thanks, Sylvia.
So I have a question, a couple questions. One, Kathleen, if you could talk a little bit more about your tool, the Connect 6, and whether or not that could be integrated into, or we could get data from electronic medical records. That is something that, another area for potential scale and spread as we think about development of new ways of using electronic medical record data to help with sort of decision support at the practice level, but also then, of course, a foundation for learning health systems more broadly. So that's one thing. And then, Walter, we just have so much to talk about in terms of standing up. We're also standing up a policy briefs and evidence syntheses. So that may be an area that we could definitely collaborate, of course, also with the primary care community. So Catherine, do you want to start, and then Walter can answer?
Yes. So Connect 6 was developed to be completed by the patients. It's 6 yes or no question about their health, their social support, pain, something like that. So, and it's yes or no question, and it's positive if there is 2 yes answers or more. It's a good question if it could be transformed or adapted to be, or it would be an interesting research project just to evaluate if we can obtain valid results with databases information. So, but it was not developed for that purpose initially. Yeah.
Okay, future work for us to work on.
Yeah, we could collaborate about that.
In the collaborations, Sabrina, I think like that's a great idea if you're developing policy briefs and knowledge mobilization products, and we can contribute to them, but also share them through the platform. I think our intention, one of the things when we gathered our implementation science teams together in the fall, was looking for synergies and opportunities to really collaborate across the teams, and just sort of setting it up to bring people together without a purpose was hard for people to imagine like why they would do that. And so what we've decided is that we would start with community. So I'm really glad Monica made that comment, because to bring in the problems that the system is trying to solve for, and then bring the collaborative knowledge across those communities of knowledge users, primary care providers, other providers, patients, family caregivers, to address what that current knowledge state is, to develop briefs to address those problems. So we'll be a little bit problem focused, as opposed to just, hey, here's the knowledge we have, and I don't know if anybody can use it or not, but here's a brief on it. So we're going to be a little bit tasked. And so our first year is really getting a bit of a lay of the land of what some of the issues and challenges are that are facing knowledge users, starting with the knowledge users that are part of the think teams, but then very much, already expanding. And this is a great opportunity for us to start that activity with Monica, with Philippe, and others.
Yeah, I mean, I think it's great for the decision makers. So as an example, Monica and someone from Alberta, Judith, worked with us in terms of CPCRN, doing a best brains exchange on team-based care evaluation framework. And from that, we have a report. And in March, we're having a workshop to further develop this evaluation framework with common domains and indicators. So it's just a great way to have decision makers come with problems that are relevant for them, and then to bring knowledge and experts to the table to really help to continue to push forward and sort of help to solve some of these issues. So, yeah.
Yeah, and I appreciated being invited to join that activity a little bit. So, and I think our connections into the teams is, we're really just getting to know the teams right now. We're actually conducting meetings with every single one of the teams just being set up so that we can know them more in depth about what they're doing, and we'll be better able to link in to those solutions when the problems arise. For example, like the extent of team-based care, to the extent to which that fits into the different models, we're just learning about that now, starting to.
Yeah, no, I think it's going to be great. Other questions or comments? Tracy.
To see you. I'm on one of the IST from the Think project in Saskatchewan. And I was just wondering, within NICE, and I may have missed it, sorry if I did, is there an evaluation plan for NICE embedded to know whether or not what you're doing is getting you what you want?
We have the elements of that. We are, as part of our program, also going to be studying like the best ways to put into practice. So we have a number of evidence-based approaches here that we're taking, right? Like I didn't highlight them in that way and in that regard, but learning communities are part of that evidence-based practice, policy briefs, and kind of the learning series, which is a bit more of lectures, and building capacity. And then, our sense is also to have an increase in the number of connections that people have across the teams and into the teams, right? Like fundamentally, relationships lie at the basis of a lot of impact. When we're actually working in this space, like knowledge is one thing, but actually impact built on relationships. So that's one of the things we'll be measuring and marking over time. So yes, and we're trying to get up and running, and then we'll kind of come in with some evaluation and elements of it. But yes, we are trying to study how we do this.
Great to hear.
And we just learned a little bit more about the Saskatchewan program yesterday, and we spoke with Gary last evening.
One of the things that we're doing over in the CPCRN as we build this consortium, the CPCRC, is to try to undertake a developmental evaluation. So maybe we can share some insights and learnings as we move forward, so that we can help set up developmental evaluations, because I think they could be pretty useful in terms of lessons learned and traps to avoid. And obviously, Catherine and your team, you have a lot of experience trying to set up Visage and PriCARE, etc. So I want to thank everybody for coming today. Catherine, Marie-Dominique, Philippe, and Walter, as well as all the people who came to this seminar. And next month, we'll have a learning session specifically devoted to talking about an update on the consortium, which will be led, I think, with O'Neill. O'Neill's leading that with Ayat, Salmon, etc. So we'll look forward to seeing you next time. Thank you, everybody, for joining.
Bye, everyone. Thanks.
Bye.
Thanks very much. Appreciate it.